Got about a half hour left. We'll kind of fly through these. The REM parasomnias are interesting, but there's a smaller number of them, so less to know. Okay. Um, the big REM parasomnia to know is REM behavior disorder. The second is recurrent isolated sleep paralysis, and the third is nightmare disorder. That's it. Okay, so we're going to spend most of the time on RBD. So the full clinical disorder was described about 40 years ago, but there's an animal model of RBD that had been described about 20 years before that. Clinically, RBD is characterized by the following things. So you've got vigorous or violent motor activity arising out of REM sleep. There is often dream enactment activity that may be self-injurious or injurious to a bed partner unintentionally. The dreams tend to have this common theme of being chased or attacked or pursued. And that's a very common finding that you'll hear from people who have and then if they're awoken during the event, in contrast to a non-REM parasomnia, they're going to be alert, they're going to have pretty clear dream recall, and it tends to correlate with the behaviors that were being observed. Okay, picture's worth 1,000 words. Let's see what this looks like. And that's the end of the event. Interestingly enough, this is a year after the syndrome was discovered and described, so it's a very early video. But a couple of things are worth pointing out. And let's turn. So you see these kind of vague, purposeless movements, but a couple are important. There's some flexion in the fingers, and you'll see some kind of bicycling, locomotor movement in the feet. There we go. Then complex behavior, he's swatting or hitting something there. Gets one more punch in for good measure. So some of the videos of the non-REM parasomnias we watched were pretty complex and hard to distinguish from that, but this is unique in that it's very coordinated activity, right? You have the movement of the legs as if in locomotion, you have the hitting or swatting kind of defensive measure, and it lasts a good bit longer than those non-REM parasomnias did. Okay. RBD is rare, 1% at most, but in older folks, it becomes more prevalent. And the peak age at which it becomes apparent and diagnosed is in middle-aged and older men, more so than women. 40s to 70s. 40s is not middle-aged, just saying. So usually this happens in the second half of the sleep period, especially the latter third of the sleep period, again, because we have more REM in that period of the night, and all kinds of different behaviors can be seen. It really just depends on what you're dreaming about. So let's watch some more videos. This is a much quicker example. Yeah. But similar to before, there was, I'm just going to go back, there was sort of a partial locomotor action down there, and then self-defensive maneuver. Yep. Slammed his hand against the night table there, and then right back to sleep.
With the eyes open before he started.
Yeah, yeah. So eyes open or closed is not a super a helpful determinant between awake and asleep or non-REM and REM. You can still have well, so the issue is in REM sleep, you should have skeletal muscle atonia, but you don't. So the typical rules about low muscle tone in REM, sort of small movements at most, goes out the window because normal muscle tone is better.
So like the twitching you see during dreams.
Yeah.
So that's not,
Yeah, yeah.
but this is like they're bigger.
Exactly. Typical REM movements, not an RBD, would be very rapid kind of flexor movements in the fingers. Those are the most common REM movement, and the rapid eye movement, obviously. Let's watch another one. That was more lower extremity, right? Quick, either running or kicking or whatever that was. But again, were we monitoring EEG, you'd see REM sleep the whole way through.
You would remember.
Hmm?
You would remember.
Yes, yeah, yeah. If well, I'll say this: if you woke him up, he would remember it. But if so, he's being recorded for other reasons. So if you played this back to him, he might not remember it. You know, the guy who smacked his hand against the night table, he very likely woke up after that just because of pain, discomfort, etc. And he would likely be able to describe what he was dreaming about and would have a memory. Okay. This is sort of a recapitulation of what we talked about before. So wake and sleep can exist in sort of an admixture in different areas of the brain simultaneously, which is how all parasomnias arise. But here's an interesting sort of study in the literature. So this is a person, a young man with epilepsy, and he is getting actually sort of an open skull intracranial EEG. We don't usually get to do this, but what this shows us is in the kind of frontoparietal areas here, we see ongoing slow wave sleep activity. Whereas in sort of more motor cortex, temporal areas, you have the sustained fast activity. What is this telling? I mean, the only thing I'm trying to show you here really is that the brain activity doesn't have to look the same everywhere you look. So this is one way that parasomnias can arise, that you have activity in the motor cortex, even though a larger swath of brain tissue is still asleep. You're never going to see this on a sleep study. This requires intracranial monitoring, right? But the reason I'm showing this is because it's an interesting proof of principle. So this shows us directly what we knew theoretically, which is that parts of the brain can be awake, whereas the majority of the brain is still asleep. Parenthetically, you haven't had much experience with EEG yet, but do you know what those are? So those are spike wave discharges, epileptiform discharges. Yeah, so the more it looks like EKG, the bigger problem it is. Yeah. So usually epileptiform discharges are not that beautiful and sort of obvious. So when you see them like that, it's an easy call. Okay. All right. So an important concept to understand is that REM behavior disorder is correlated with other neurologic disorders. Narcolepsy would be one large group of related disorders, and then neurodegenerative disorders is the other group. Carol Rosen, who was over at Rainbow and is kind of one of the godmothers of pediatric sleep medicine, has this great adage, which is RBD in kids is narcolepsy until proven otherwise. You're not going to see it a lot in kids, but if you do, you should strongly suspect and look for narcolepsy. Not so in adults. Adults with narcolepsy will have RBD, but it's more often associated with medications, other conditions, et cetera, which we'll talk about. But the big one to worry about is the alpha-synucleinopathy, so the kind of Parkinson's disease spectrum. So there are shared kind of pathological lesions, especially in the subdorsolateral nucleus, from alpha-synucleinopathy deposition. That kind of underlies both conditions. Why is this important? So RBD may emerge 10 years before the other symptoms of a Parkinson's disorder. So in an older, middle-aged or elderly person that you're seeing for RBD, one of the things you have to keep in mind is this RBD related to an as yet undiagnosed neurodegenerative condition? Usually not, but it can be. And obviously that has important implications for counseling and discussions and prognosis. No, you as a sleep doctor are not going to be the one to tell them that they have Parkinson's, right? But you may want to sooner rather than later get them hooked up with a neurologist or what have you. Looking at it from the other way, in people who have Parkinson's disease, up to half have REM behavior disorder. In multiple system atrophy and the flavor of Parkinson's, 80 to 95% have RBD, and about 80% in dementia with Lewy bodies. Now, the reverse is not true. It is not true that 50% of people with RBD have Parkinson's. Okay? So it's maybe 10 to 15%. But the important differentiating factor is idiopathic versus primary RBD. Idiopathic versus secondary RBD. Secondary RBD is more common. Secondary to meds, other sleep disorders, etc. That's going to be the majority of cases of RBD that you see. You're going to see a lot of RBD in veterans. That's probably the number one group that you're going to see. But you can see it with SSRIs, other types of medications in that category. But if you rule those other things out, and you're left with primary or idiopathic RBD, then you're looking at the strong association between the RBD and neurodegenerative disorder. And the likelihood of developing a neurodegenerative disorder sort of increases with time and age. We'll talk about that.
I have a quick question.
Uh-huh.
So for sleep studies, we typically tell patients to be off their antidepressants.
Yeah.
For concerns for RBD and the patients on an antidepressant, like would you tell them to stay off of it? Like because potentially you can see it, right?
So a couple of things. We will ask patients to come off antidepressants for MSLTs, like daytime sleep studies. But most of the time, you'll have, for an overnight study, you'll have them continue. Yeah. And the reason is, as you implied, SSRIs are REM suppressing. And so if you're looking for REM, like in narcolepsy, you don't want to have a REM suppressing medication on board. On the flip side, if you discontinue the SSRI for a brief period, you're going to get REM rebound and you can have a false positive. So the general rule with sleep studies 99% of overnight sleep studies, you're going to continue whatever med they're on. Yeah. But let's say you've got a patient who potentially has RBD. They're on an antidepressant. The first thing you're going to talk to them about is, can I get you off of this? The answer may be no, right? And that's obviously something you're going to work with their other prescribers on. But if you're not able to stop the SSRI, it's going to be tough to know whether it's a primary or secondary RBD. Believe it or not, this is a slide that's good to memorize. Maybe not today, but eventually before the boards. But the basic idea here is sleep maintenance. So sleep on off and REM on off are one pathway, and motor tone, skeletal muscle tone, is a second pathway, and they're independent pathways that exist during REM sleep. What happens is there is a direct and an indirect pathway down here to the spinal, the interneuron, all the way down to the spinal motor neuron at the muscle. So ordinarily, what's happening is the sublateral dorsal nucleus is providing sort of an activating signal to the megacellular reticular formation here, which is providing sort of negative inhibition to the motor neuron, which means you're getting less activation of the muscle tone, so you're switching off the muscle tone during REM. Well, in the alpha-synucleinopathies, you have lesions in the sublateral dorsal nucleus, meaning you're no longer getting that inhibition of the muscle tone, meaning that during REM sleep, your muscles are able to be activated. Okay, so that's the shared mechanism. That's why you get REM sleep without atonia in RBD. We've talked about this. So idiopathic RBD or primary RBD is in many cases a prodromal syndrome of neurodegenerative conditions. And up to 64% of idiopathic RBD patients eventually develop a neurodegenerative syndrome. This is over time. So if you're talking, you've got an RBD patient in front of you, you've confirmed that they're idiopathic, the likelihood of developing a neurodegenerative condition within 5 years is probably 15%. 7 years is probably 18%, 10 years is probably 25%. So this is sort of a scaled factor here, but the idea is that the RBD symptoms, if it's idiopathic RBD, may precede the symptoms of Parkinson's, Lewy body dementia, whatever, by a decade, usually at least 5 to 7 years. Okay. Something to know, but I don't think something you need to memorize necessarily. There's lots and lots of other things that can contribute to RBD, lesions in that pathway that we looked at, particularly in the pons, which could be stroke, demyelination, et cetera, et cetera. It is usually a good idea if you've got a patient with idiopathic RBD, to think about neuroimaging in them. You obviously have the option to defer that to neurology, but at some point you're going to want head imaging. Hello, how are you? Good. Have you had a chance to meet Dr. Altani yet? Well, here she is. Nicoletta's an adult and pediatric sleep doc who's been on the faculty for a number of years. And we'll be teaching about RLS, which is much more interesting than this. Okay. As we talked about, lots and lots of medications, but especially SSRIs, to a lesser extent SNRIs, can be responsible for secondary RBD. Okay. very quickly, there are a number of questionnaires that have been developed and validated for screening RBD. If you're doing RBD research studies or whatever, you may want to look into these. But typically in clinical practice, you're going to be asking questions like this. Do you seem to act out your dreams while asleep? Or do you kind of kick or hit during your sleep because you're dreaming of having to protect yourself? I like this second phrase here. This is not validated, by the way. This is just sort of anecdotally the way we ask it, because it's specific enough to weed out random movements that bed partners may notice, but it's not so hyper specific as to exclude the variety of phenotypic expression in RBD.
The validated screeners, are they limited to just adults, or can we also use those on children?
That's a good question. To the best of my knowledge, these have only been validated in adults. Okay. Home stretch, but probably the most important slides. So the ICSD-3, now TR, tells us what we need to look for RBD. So one, there need to be repeated episodes of sleep-related movement or vocalization. This is the most important part. They need to be documented during REM sleep or assumed to come from REM sleep based on the history. And 3, PSG demonstrates REM sleep without atonia. And 4, it's not due to something else. 2 and 3 are important because they're sort of how you're differentiating this from non-REM parasomnias. And 3, this is the only parasomnia that requires PSG diagnosis. Okay, so let's talk about REM sleep without atonia. REM sleep without atonia is not unique to RBD, but it is a required feature of RBD. You can see REM sleep without atonia in other conditions, which I'll show you in a second, but you need it if you're making a diagnosis of RBD. Okay, so there's 2 ways you can get it. You can either get sustained or tonic elevation of usually the chin EMG, or you can have transient muscle activity in either the chin or the limbs. Okay, so tonic elevation or transient or phasic elevation. Sometimes you get both. Picture, okay, 80-year-old guy being evaluated for recurrent violent nighttime awakenings. So EEG shows mixed frequency, relatively low amplitude activity. He's got rapid eye movements. You see both sustained and intermittent elevation of the chin tone. And you see intermittent movement of the left anterior tib. Importantly, this is not during an arousal, right? During an arousal, the movement can be totally normal. But the EEG doesn't change, it remains in REM, and so this would meet criteria for excessive transient motor activity, which gives you REM sleep without atonia. Similarly, if you're suspecting RBD, you can do an extended EMG montage. So beyond just the left and right anterior tib, you can do higher up on the legs, arms, face, etc. So typically we do like 8 different muscle groups instead of 2. If you're looking for RBD and either sustained or transient motor activity in any of those can count for the REM sleep without atonia. Having said that, REM sleep without atonia is not unique to RBD. So here's an example from a patient we saw a couple of years ago. So he's in REM sleep. This is a split night study. And again, I realize you haven't read a whole lot of these, but if you look at the nasal pressure signal, he's got some normal breaths. He develops flow-limited breaths. He develops hypopnea associated with a desaturation, terminated by an arousal. Okay, so he's got sleep apnea. Fine, but the reason I'm showing you this is you look at his chin tone, this thick, so that's abnormally high in REM sleep. But you put the guy on CPAP, and it goes right down. So I don't exactly remember if this guy was complaining of dream enactment, but if he was, this is something you would call pseudo RBD. Right? So it is a manifestation of the sleep apnea, which is causing the REM without atonia, but it's not the primary REM. Similarly, this is a patient with RBD in REM sleep. You can see quite normal breathing. They've got intermittent, well, sort of both sustained and intermittent elevation in the chin tone, as well as very frequent transient movements here in both legs. So this would be kind of a no-brainer REM sleep without atonia case. That's showing us the same thing. Okay. The differential, again, is essentially non-REM parasomnias versus anything else that might disrupt sleep or cause abnormal behaviors. I wouldn't spend too much time on this slide personally, but let's conclude with treatment. There are two treatments available, assuming it's not related to an offending medication or untreated sleep disordered breathing, and those are melatonin and clonazepam. The mechanism for both of these is not terribly well understood, despite what it says on the slide. But the thing to know about melatonin is typically you need quite high doses. So you'll start at your standard 3, 6, etc. But it's not uncommon that you might use 20, 30 milligrams of melatonin to treat RPD.
Do they recommend like extended release versus immediate?
No, and in my experience, usually the short acting stuff is good enough. Okay. Yeah. And then clonazepam, similar to your typical application, you start at a low dose, 1/4 milligram, and work your way up. If I have the option, I will typically start with clonazepam, especially if there's no sleep disordered breathing, it works better. But if there is any reason that you wouldn't want to use a benzodiazepine, and there could be lots, these tend to be older people, poor balance, etc., then it's reasonable to start with melatonin. Okay. There are other therapies with limited evidence. We've only got about 5 minutes, so I'm going to blast through here. RBD is the big one. We've got 2 more REM parasomnias to talk about: recurrent isolated sleep paralysis and then nightmare disorder. Sleep paralysis is kind of like the opposite of RBD, right? RBD is lack of atonia in REM sleep. Sleep paralysis is persistence of REM atonia into wakefulness. Okay. So you have skeletal muscle paralysis, you have preserved eye movement and diaphragmatic movement. And typically sleep paralysis comes along with sort of vague dream material, a sense of fear, again, being pursued, etc. It's very common to feel heavy-chested or smothered. Again, your intercostal muscles don't have any tone, you're just relying on your diaphragm for breathing. And these tend to be short. These tend to be terminated by an external stimulus, if there is an external stimulus, but they always seem way longer than they are. Sleep paralysis, well, here, before I go to that, ICSD says this: there's recurrent inability to move the trunk and all the limbs at sleep onset or awakening from sleep. Typically, it's awakening from sleep. Each episode lasts seconds to a minute or so. There's distress associated with it, and it's not better explained by something else. These are pretty vague diagnostic criteria. You'll know sleep paralysis when you see it. Patients are typically very clear about what they experience. It's not sluggish, I can't get out of bed. It's I'm terrified. I'd jump out of bed if I could, but I feel like there's an elephant sitting on my chest. Parenthetically, it's assumed that sleep paralysis is responsible for kind of historical and mythological accounts of demons and things like that. Okay, so sleep paralysis is common. Okay, isolated sleep paralysis happens in as much as half of people at one time or another. Sleep deprivation, jet lag, shift work, alcohol can all cause it. But the recurrent nature is what makes this a specific diagnosis. So if the episodes are infrequent, really nothing to do. If there's no other symptoms, good sleep hygiene, avoid sleep deprivation, avoid exacerbating factors, fine. But if they're frequent and recurrent episodes, then you may want to treat. First thing I would ask about very carefully is narcolepsy. Sleep paralysis is not a cardinal, but an adjunctive symptom of narcolepsy, and is almost ubiquitous in people who have type 1 narcolepsy. That being said, if they're not sleepy and they've got this, your diagnosis is pretty much wrapped up. But I would look for things like depression, again, screen for other medication use. Typically, treating sleep paralysis these days involves either kind of a low dose of fluoxetine or a low to moderate dose of venlafaxine. Those would be the two most common treatments. And often it's for their REM suppressing characteristics. Okay. Last one, nightmares. Essentially universal, right? Nightmares happen in REM. They're not a disorder. Everybody gets them at one point or another. Peak ages in kids between 6 and 10 years of age, but nightmare disorder needs all of the following. You have repeated occurrences of dysphoric, well-remembered dreams. B, you rapidly become oriented and alert when you wake up, i.e., that's what happens when you wake up from a dream, right? And then C, they're causing some kind of distress as manifested by, 1 through 9, any of those. So the idea here is it's not just any nightmare, it's frequent nightmares that are causing functional impairment or distress of some sort. Differentiating this from something like PTSD is challenging. Usually a diagnosis of PTSD would supersede nightmare disorder. Nightmare disorder is kind of folded into the PTSD moniker. Let's see. So besides PTSD, any sort of behavioral disturbance or issue can be a potential trigger of stress, anxiety, trauma, what have you. But various medications can cause frequent nightmares, statins, Chantix, various antimalarials, etc. Exactly. So usually don't need treatment, and if you are going to treat them, you usually don't need to treat pharmacologically. Usually you can treat with various cognitive or behavioral therapies, but prazosin and to a lesser extent trazodone have some evidence for nightmare disorder. But I would say the most common treatment is image rehearsal therapy, which can be done in the sleep clinic, but is best done with a licensed therapist. Or
I feel like it's pretty easy with kids, just because you just choose the brain.
Rescripting. Yeah, rescripting. So as you mentioned, this is essentially repeating and rehearsing the dream activity, putting it in an emotionally neutral context, plus minus rescripting, which is what you talked about, which is now the witch chasing you is a friendly bear and you have a tea party, that sort of a thing. That can be very effective. There are more advanced psychotherapeutic approaches involving sort of eye movement desensitization, response therapy, lucid dreaming, exposure and desensitization. Those are much harder to do in the context of a sleep clinic. And again, you're probably going to refer to a mental health professional specifically to do those. Okay. I'm going to do this real quick. This is actually not a parasomnia. Have you guys heard of cataphrenia? So cataphrenia is expiratory groaning.
What's the one they confuse with like apneas?
Yes. So this, I need to fix these slides. This is not parasomnia. It's actually classified under sleep disordered breathing. Okay. Come say hi.
Lisa, I'm the sleep coordinator. Give you guys my card. I work Monday, Tuesday, Wednesday, Fridays. Sometimes at Parma, one day here. Welcome, everyone.
Thank you.
All right, that's all.
Thanks for dropping in. So the most common way you'll encounter it is you're reading sleep studies, if it's like a priority study and you want something communicated to the patient, send the chart to her, she'll call, she'll let you know the result of that. If you want to order therapy, she'll counsel the patient on that. We don't do that for every study, but if it's something tagged as a priority, that's okay. Yeah, cataphrenia is a type of sleep disordered breathing. It's expiratory groaning. It was reclassified when we switched versions of the ICSD from parasomnia to sleep disordered breathing. Typically happens in REM sleep, but it may happen in so couple of questions and then turn it over. I apologize for going long here. Which of the following are not associated with recurrent isolated sleep paralysis? A, hallucinatory experience. B, event duration seconds to minutes. C, sleep deprivation is a predisposing factor. Or D, excessive daytime sleepiness. It's not an easy one. Yeah. Right. So hallucinations are common in sleep paralysis. They tend to be short. Sleep deprivation is the most common predisposing factor. So if you're meeting somebody with like a first time episode of sleep paralysis, like the most common thing is the college student pulling an all-nighter, that acute sleep deprivation and recovery from that sleep deprivation can be a common cause for this. Okay, 75-year-old guy, history of Parkinson's. He's being treated with Cinemet, has RBD and is following up. PD is relatively well controlled. He's also taking melatonin 10, which you prescribed for his RBD. Since the melatonin started, he describes improvement in his awakenings and motor activity. In addition to those two medications, he takes metformin, carvedilol, and drinks 1 to 2 glasses of wine. Which of the following has the potential to trigger or exacerbate RBD? A, increasing the dose of Cinemet. B, taking carvedilol. C, alcohol withdrawal. Or D, chronic benzo use. Say again?
B.
B. Why do you say B?
I don't know, I might be confusing that.
It's a really good answer, actually. Now, I'm thinking about it because I didn't write these questions, but I want to see if that's right or not. Yeah. So I think the answer he wanted here was alcohol withdrawal. However, the reason I'm going to say that C is a better answer than B, B's not wrong, is because carvedilol is very cardioselective. But the non-cardioselective beta blockers, propranolol, metoprolol, suppress melatonin and can exacerbate RBD. I realize this is not the lecture, but patients with insomnia who are taking a non-cardioselective beta blocker, if you can switch into something like carvedilol or move the beta blocker to the morning, you can often improve their insomnia.
Okay.
Next year, I'm going to have to revise these slides. Okay, last but not least, this is, for the life of me, I don't remember who painted this, but we have a famous rendition called The Nightmare And this is meant to depict not just a nightmare, actually, but sleep paralysis. So hallucinatory figure, the sense of somebody's sitting on your chest and being unable to move. Well, anyway, that was a super quick world